Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello, and welcome to the Advancing Surgical Care podcast. I'm Newbury, Chief Advocacy Officer of the Ambulatory Surgery Center Association and host of this recording. My guest today is Dr. David Kenigsberg, a clinical cardiac electrophysiologist and a member of ASCA's Cardiovascular Working Group. Dr. Kenigsberg is a graduate of the University of Miami School of Medicine. He also completed a 2-year electrophysiology fellowship at the Virginia Commonwealth University Medical College and is currently board certified in internal medicine, cardiovascular disease, and clinical cardiac electrophysiology. I've invited Dr. Kenigsberg to join me in a discussion about performing certain cardiovascular procedures in the outpatient setting. In particular, we will be discussing cardiac electrophysiology procedures that ASCA has asked the Centers for Medicare and Medicaid Services, or CMS, to authorize for reimbursement in ambulatory surgery centers. For those not familiar with authorizations for Medicare reimbursement, CMS must determine that a procedure can safely be performed in an ASC and add that procedure to the ASC Covered Procedures List during rulemaking before an ASC can treat a Medicare beneficiary. Each year, ASCA submits procedures to CMS supported by clinical data that we believe can and should be permitted in ASCs. In March of this year, we submitted a total of 16 cardiovascular codes, including several cardiac electrophysiology. Unfortunately, CMS did not include any of these procedures in the 2025 proposed rule. We'll talk more about those procedures and the regulatory process in a moment. But first, let me welcome Dr. Kenigsberg to the podcast.
Thank you very much, Kara. This is a great opportunity for me to chat with you all today, and I appreciate you inviting me.
Yes, thank you so much for taking some time to really educate our audience. So, Dr. Kenigsberg, could you first take a moment and tell our listeners more about your practice and the patients you see and treat for cardiovascular issues?
Yeah, so I'm an electrophysiologist down here in South Florida, and I have quite a few patients that are of retirement age, hence a very large Medicare population. I work out of a number of hospitals and also work out of an ASC. That is a location in East Fort Lauderdale that's very convenient for patients with a very large catchment area and right next to a major hospital and nearby other major hospitals. The patients basically come in from the parking lot, get registered, walk a short distance to the pre-op area, have their procedure, either a pacemaker, a defibrillator, a biventricular defibrillator, and then are recovered and go home within a few hours. My patients find that extremely convenient. It's a very safe environment. And to date, we've been blessed with very few to none untoward complications to our patients. Our patients have done extremely well, and we're very pleased with the outcomes. The ablations that I currently do for all patient types, patients from 18 to into their 80s, are currently done at the hospital. Mostly, as I mentioned, because Medicare dictates where we can safely do a procedure based on their reimbursement. Obviously, patients are permitted to pay for procedures out of pocket and go wherever they'd like. However, currently, Medicare beneficiaries, in order to take advantage of the money they've paid in, must do it at an approved site. And the site of service of an ASC is currently not permitted to allow for ablations according to CMS. I do at least 350 atrial fibrillation ablations a year and a few hundred other type of ablations a year, in addition to hundreds of cardiac implantable devices, as I aforementioned. I'd love to be able to take some of the healthier and lower acuity patients out of the hospital setting and safely perform their ablations in the ASC setting, as I think this would be a tremendous cost savings to Medicare and private payers, and a huge benefit to the patients and improve their satisfaction.
So I think you touched on this somewhat, but from your clinical perspective, is there a safety rationale behind CMS's refusal to add some of these cardiac ablations to the ASC Covered Procedure List? And could you also just give a little bit more of a primer on what these procedures entail, maybe from a patient's point of view?
Sure. So first off, a device implantation is a patient comes to the procedure room. They get some, what we call conscious sedation, a little bit of morphine type drug and a little bit of Valium type drug. The patient is then well anesthetized locally with some lidocaine, similar to what they'd get at the dentist. And then a 3-centimeter incision is typically made in the left chest area. A pocket is formed. Access to the vein is obtained. And 1, 2, or 3 wires are placed into the heart under X-ray guidance. Once the wires are in the proper position, a small screw is released or the lead is advanced as distally as it can be. And then the leads are sewn down, connected to a generator, which is the brains of the device, and the pocket is sewed up. It takes about 30 minutes, and the risk of that procedure is far less than 1% chance of complication. That is currently being done in cardiac ASCs throughout the country and has been for some time with a great safety profile. The procedures that we're asking CMS to allow us to safely do in ASC setting also carries about a 1% risk of acute complication. That procedure is called an ablation. An ablation means to treat or destroy an area of tissue with energy, in this case, the heart. What we do for that procedure is similar in the sense that the patient comes in, they're given some medication to go to sleep. There are different levels of sleepiness that we would allow for. Some people will be under conscious sedation, some moderate sedation. There could be procedures that we do under general anesthesia. Regardless, the patient will go to sleep. We'd clean and prep the area that we'd get access, usually the right and left groin areas where the femoral veins are, or the arteries, depending on the type of arrhythmia. And then we would thread small catheters into the heart in order to map for an arrhythmia, potentially induce or bring out an arrhythmia by pacing or giving drugs like adrenaline, isoproterenol. And then once we figured out where the arrhythmia came from, using mapping or deductive reasoning, then we would go and target that area with an ablation or a treatment catheter, which could involve radiofrequency, which is loosely called burning, cryothermal energy, which is freezing, laser energy, which is self-explanatory, or the newest form of energy, which is pulse field, which is proven to be very safe, efficient, and effective. That procedure, as I mentioned, regardless of the arrhythmia type or the catheter used, has about a 1% risk of complication. That is less than or similar to thousands of types of procedures that are currently performed nationwide and worldwide in ambulatory surgical centers. And probably in comparison to some things that are done every single day, like for instance, liposuction, it's far safer.
This episode of the Advancing Surgical Care podcast is brought to you by AmSurg, a national leader in the strategic and operational management of ambulatory surgery centers. AmSurg partners with more than 2,000 physicians and health systems and more than 250 ASCs operating in 34 states. Learn more by visiting amsurg.com.
Very interesting. Thank you so much, Doctor. I think that ties in nicely to our next question. CMS staff often ask for outcomes data. Can you comment on relevant? And I know that there's recent data that exists for these procedures.
Yes, myself and colleagues have actually published recent data on this topic in the Heart Rhythm Journal with over 4,000 patients that we looked at for all types of electrophysiology procedures, including all device implantations, transesophageal echocardiograms, and ablations. Actually, CMS did approve ablations during COVID in a program called Hospital Without Walls because patients could not get into hospitals. They were overrun with sick COVID patients. And during that time, thousands of ablations actually occurred in this country under the eye of CMS that were approved and paid for by CMS. And the data and the outcomes were excellent, on par with what I've aforementioned, which is about less than a 1% procedural complication rate. This paper that I'm mentioning has that data as well as other procedure data, which shows a very low complication rate and high patient success, good outcomes in a large patient cohort from across the country, including as far north as Alaska and as far south as South Florida.
That's fantastic. Thank you to you and your colleagues for really pulling that information together and getting it out. We at ASCA have been very familiar with the Hospital Without Walls program, and CMS has found much of that data that's been collected across different specialties compelling in the past. So I'm optimistic that CMS will consider this data as well. Is there anything else that you'd like to add?
Yeah. Having been partaking of performing procedures in an ASC setting since 2019, I have to mention, I can't think of a single patient that didn't thank me for bringing them to the ASC and keeping them out of the hospital. Hospitals could be very dangerous places. There's a lot of patients that come through there. There's a risk of hospital-acquired infection. Some of my patients are elderly. They can't walk very far down long corridors, or they have to be transported. This is very safe, effective, convenient, and patient-friendly. At the end of the day, we're doing this for our patients. So don't we want our patients to have the best possible outcome in the best possible setting and have great things to say about their patient experience? If you want that to happen, then ablations have to happen in an ASC.
Well said. Very well said. Dr. Kenigsberg, ASCA's ability to advocate on behalf of our members and the millions of patients that we all care for are heavily reliant on the contributions of medical experts such as yourself. So on behalf of ASCA, I want to thank you for taking the time to speak with me today and for volunteering your expertise to our cardiovascular working group. I know that you're also involved with the Heart Rhythm Society, and ASCA has really started collaborating a lot more closely with that organization in the past year or two as well. So I am optimistic that in the near future, we see these codes added. But once again, I just want to thank you, Dr. Kenigsberg, for your time.
I just want to mention a couple more things. Some organizations outside of Heart Rhythm Society that are very eager to see this happen. Namely, I spoke last weekend, Kathy Biga, the president of the American College of Cardiology. She was at our Florida chapter meeting in Orlando, and the ACC stands behind this effort. They see this as a patient-centric effort. The ACC wants to see ablations in an ASC setting, and they've actually led the way for this to happen. And I'm pleased that Kathy is a big proponent of this happening. As far as HRS goes, Dr. Kenneth Ellenbogen is my mentor. He trained me while I was in Virginia. He's the current president of the Heart Rhythm Society, and he too would like to see this happen. He's been very involved in making sure that this is a safe setting. And he's very pleased from what he told me with the data that we were able to provide based on the research that's been done and published in the Heart Rhythm Journal. And so I'm very pleased that he's advocating for this as well. I also am aware of another group of electrophysiologists that are getting together to advocate for ablationists in the U.S. This is called the Arrhythmia Intervention Society, and I'm part of that as well. And we too are very keen on seeing this happen. So you have lots of physician bodies that know a lot about cardiology, a lot about electrophysiology, a lot about patient care that want this to happen.
And really, I think our best opportunity for success is to all pull together. So that is fantastic to hear. Thank you so much, Dr. Kenigsberg. And before I conclude, I just need to acknowledge the support of our podcast sponsor, AmSurg, a leading ASC management company with more than 250 ASC partners in 34 states. To learn more, visit amsurg.com.